Good day, everybody, and welcome to our organized session of the thematic working group on strengthening the role of community health workers in health system development. You're very welcome to our small webinar. I am Marise Kok. I'm a health systems researcher focusing on community health, and I'm working at the Royal Tropical Institute in Amsterdam. And I am part of the thematic working group on community health workers. Our thematic working group of Health Systems Global really focuses on the role of community health workers in health systems and to share experiences and evidence, research and practice around these programs all around the world. We really would like to enable learning across different settings. And today's session, we are going to focus on the role of community health workers in fragile and conflict-affected settings. Community health workers play an important role in the provision of community-based services, and also where formal health systems are temporarily weakened or dysfunctional. Community health workers also play an important role in emergency and disaster preparedness and response. And we see that now with the COVID-19 pandemic, but also earlier disease outbreaks. And also they play a role in responding to natural disasters. There's quite a large body of evidence on community health worker programs around the world. And based on this evidence, in 2018, the World Health Organization published a guideline on health policy and system support to optimize community health worker programs. Despite this, there is still a need to really learn more about the role of community health workers and how effective community health worker programs look like in fragile and conflict-affected settings. And that's why we are focusing on that today. We would like to identify lessons learned about the role of community health workers and in these settings, and also make recommendations on how to optimize the use of their the potential of community health workers in emergency preparedness, response, and health systems recovery in fragile and conflict-affected settings. We have 4 presentations, and after that we have Q&A and discussion. If you would like to ask a question to one of the panelists, you can do that in the Q&A live box. And you can also provide more general discussion points in the forum. We start with a presentation that is providing an overview of what is known from the literature about the role of community health workers in conflict-affected settings. And then we have 3 country case studies that go into depth about Sierra Leone, DRC, and Malawi. And again, if you have questions to the panelists, feel free to put them in the Q&A box. And at the very end of the 4 presentations, we will address them and go into a general discussion with the panelists. The first speaker of today is Dr. Nate Miller. And he is a consultant and adjunct assistant professor at Columbia University. And he has 16 years experience in conducting research, providing technical support, and implementing maternal, newborn, and child health interventions in sub-Saharan Africa and Southeast Asia. And he spent the last 6 years as the focal point on community health in humanitarian settings at UNICEF headquarters. And currently he is supporting the development of national community health worker programs in Somalia and South Sudan. So a great experience, and we are very happy that you could join us to present on community health workers in humanitarian settings, the results of a scoping review. Nate, the floor is yours. Thank you.
Thank you, Marisa, and thanks everybody for joining. I think you can see and hear me okay. So let me jump in. I think for the person moving the slides, you can just sort of go through the next 3 slides fairly quickly while I speak. So a number of international organizations have been promoting the use of community health workers in humanitarian settings, as these pages show, but there has been not that much evidence underpinning these recommendations. It's more been anecdotal evidence suggesting that community health workers will be useful in humanitarian settings, but there hasn't been a lot of rigorous evidence to back this up. Next slide. So for the last 6 years, I've been working with UNICEF as well as Save the Children and the International Rescue Committee to carry out a number of country case studies to provide more evidence on this topic. So we did studies in conflict settings in South Sudan and Yemen, and then also in the West Africa Ebola outbreak, and in Bangladesh in a natural disaster setting. Next slide. And so that leads to this literature review, which is sort of the culmination of this work. So the objective of this review was to, was to map out the existing evidence and to document experiences with health and nutrition services delivery by CHWs in humanitarian settings. So we conducted a search of 9 databases of peer-reviewed literature, as well as requested gray literature from the major global health coordination bodies and screened references of other papers. We reviewed about 3,700 documents, and 219 of those were included in the review, of which 175 were peer-reviewed articles. Next slide. So moving to the results of the literature review, we see that the majority, 38%, were from sub-Saharan Africa, followed by the Eastern Mediterranean region, 29%, and then followed by the Southeast Asia region. Next slide. So a majority of these papers were from conflict settings, followed by disease outbreak, natural disaster, and then just a couple nutrition emergency. A large majority, 83%, included general population settings, so outside of a camp setting. 21% were in a camp setting. A few papers included both settings. That's why the total is more than 100%. Next. So the first lesson was that there is really a clear need for community-based services in humanitarian settings. A number of papers described the decreased access to health facilities in these settings because health facilities were closed, looted, their supplies were taken, staff were unavailable, they were gone, and it was difficult for people to travel to the health facilities because of security concerns. Also, in a number of cases, governments neglected health services in opposition-controlled areas, and a number of studies showed that community-based services were more resilient in these settings than health facility services because of the greater trust in the community health workers and the accessibility of community health workers in the communities. In terms of maintaining essential health services, so in most cases, the CHWs were able to continue providing their services in different emergencies in conflict, outbreak, natural disasters. There were often pretty sharp declines in the first phase of an emergency, and then services recovered after the initial phase. There were examples of CHWs adapting their services on their own in response to an emergency. For example, in Bangladesh, with the flooding, the CHWs moved their clinic locations to more accessible locations, or they would borrow boats to provide mobile services. Also, a number of cases showed that CHWs moved with displaced communities. So they moved with their communities and continued providing the services. And they provided services for the displaced people and for host communities. And CHWs in host communities also provided services for IDPs who had come in. The major barriers to continuing services were unclear policies. So it wasn't really clear necessarily if CHWs should continue providing their services or not. This happened in the Ebola outbreak. And supply chain and supervision disruptions were major barriers. Next slide. In emergency response, the CHWs were often the first responders in emergencies. They provided care before any outside support came in. and they were more trusted in emergencies than outside actors. For example, in the Ebola outbreak, we heard about outside people coming in to provide care or to do contact tracing or to take sick people to health facilities, and they were turned away, sometimes violently, by community members. And CHWs were much more effective because they had the trust in the community. Also, local knowledge was key in emergencies. The community health workers were from those communities, so they understood the dynamics, and that improved the emergency response. Despite these advantages of CHWs were not always engaged in emergency activities, or often not in the initial phases, and they were only brought in later. So next slide. In emergency preparedness, I think the main finding is that emergency preparedness was almost never mentioned in the literature. There was only one paper that really mentioned doing emergency preparedness, and CHWs were not included in emergency preparedness plans. And we saw in many cases they weren't really prepared for the emergency. They had to sort of do ad hoc work on their own instead of having a plan for an emergency. So there were calls for integrating CHWs into preparedness plans. In policy and funding, there was short-term project funding, as we usually see in emergencies, led to closure of programs at times when the services were most needed in emergencies. In terms of flexible funding, there were positive and negative examples. So on the negative side, if funding was not flexible, then you had a difficult transition from development programming, and then an emergency hit and the development funding stopped, and then organizations or governments had to apply for emergency funding, and then eventually switch back to development funding. There were a couple cases of flexible funding where the donors allowed organizations to switch their development funding to humanitarian response and then back again. So that allowed for more efficient transitions, less breaks in service. And sustainability was really improved through integration of community health services into the national health systems. Next slide. In terms of distribution and workload of CHWs, there were often too few CHWs to cover large areas, and they were expected to travel large distances, but they weren't reimbursed for these expenses. And a key point here was in conflict settings, such as in Afghanistan and Yemen, CHWs who had to travel to other communities to provide services, they were covering multiple communities, they weren't able to travel in periods of heightened conflict. And so those communities who didn't have a resident CHW experienced breaks in service availability. On selection of CHWs, the importance of community selection of CHWs was really key. So this was key for trust and acceptance of the CHWs in the community. There needs to be, the community should select the CHWs in a transparent process. There were sometimes difficulties meeting education literacy requirements. So sometimes requirements were for, say, 8th grade education or 12th grade education. And in rural settings, in low literacy settings, it was often difficult to find people who met these criteria. So in several low literacy settings, they did recruit illiterate or low literate CHWs, and they were able to provide a range of services in these settings, although there were additional challenges, especially with reporting. And if you do recruit low literacy CHWs, it's really key to adapt the program and all the tools to this low literacy setting. Next slide. On supervision and monitoring, so supervision was often difficult to carry out in these settings because of insecurity, lack of transportation or cost of transportation, flooding made it difficult to travel to rural communities, and shortages of supervisors. Some responses to this were using local supervisors who were based closer to the CHWs and who understood the local context, and peer supervisors, so CHWs supervising other CHWs, and also use of mobile phones for supervision and data collection when it wasn't possible to visit the CHWs in person. On supply chain, so as with supervision, emergencies exacerbated existing supply chain weaknesses. Sometimes drugs for CHWs were consumed in the health facilities. There was inadequate storage for the drugs, and the travel challenges that I mentioned before. And also it was difficult to find CHWs when they had moved with their populations. and so they had to be tracked down. So some of the solutions for supply chain included NGOs creating parallel supply chains when government systems had broken down, providing buffer stocks. So in settings, for example, in South Sudan in the rainy season, it's always impossible to reach some communities for several months. So supplying the drugs and supplies for that whole period. And then in fragile settings, providing a buffer stock of maybe 2 or 3 months allowed CHWs to continue providing services in periods when there was conflict and they weren't able to reach them. Decentralized storage, so they didn't have to travel as far to get the supplies, and also inconspicuous storage locations, so they weren't a target for armed actors. And one organization provided runaway bags, so you can provide CHWs with a bag of drugs and supplies in a fragile setting, so that if they have to run with the community, they can continue providing services for a short time until you're able to resupply them. And there was a program for TB where the TB patients were also provided with a bag of their TB drugs. So if they had to run, they could continue taking their treatments. On community engagement and service utilization, so again, community selection of CHWs was key. Also engagement of trusted community leaders and religious leaders was really key to getting participation and trust of the community members. If they existed, community health committees were really important in facilitating the work of CHWs. And we saw that conflict could have positive or negative impacts on utilization of CHW services. So in some cases, people wouldn't want to open their door to somebody coming, or it was harder to do mobilization activities because of conflict. But on the other hand, the difficulties in reaching health facilities made some people want to turn more to CHWs. In terms of referrals, the challenges were often the same as in rural development settings: long distances, lack of transportation, cost of transportation. With the addition of insecurity in conflict settings, facilities were often closed in conflict settings. Facilities may lack the drugs and supplies to provide services. And in outbreaks, in Ebola and now in COVID, people may have fear of going to health facilities. So there's the issue of caring for severely ill patients in the community. I think we know in general, CHWs are not allowed to treat severely ill patients in the community. They have to refer, but in some of these settings, referral is really impossible. And there's not much recognition of this or what to do about this. There was one paper in Myanmar where when referral was impossible, they trained the CHWs to provide emergency obstetric care in the community. And this was considered to be successful. So this is just something to think about, that maybe we need to think about allowing and training CHWs to provide this care when referral is not possible. Next slide. In terms of motivation and retention, financial compensation, paying the CHWs was the key motivator, and it was really difficult for CHWs to meet their basic needs if they weren't receiving payment for their work. Also, desire to help community and community appreciation were key motivators. Next slide. In terms of security, there were many examples of CHWs and their supervisors facing really grave risks to their well-being and their security. They had to travel frequently on dangerous roads. They were in possession of valuable commodities with the drugs. Sometimes they were perceived to be aligned with one side or another in a conflict, and so they were targeted by armed actors. And then in disease outbreaks, they have increased exposure to the disease as well. So some solutions that were taken for this included providing security to CHWs. For example, in Pakistan, the polio team were provided with security. Also coordination with local communities and negotiating safe access in communities. This was really key in Afghanistan to allow CHWs to provide services in Taliban-controlled areas. In some settings in Afghanistan and Yemen, it was necessary to pair female CHWs with male CHWs, so they were more able to safely travel from their communities. Again, the idea of CHWs only working in their home communities, this eliminated the need to travel so much outside of their community and increase their safety. And also having supervisors from the local area so they didn't have to travel as far, and they also could use their local contacts to assess the security system situation in real time. And then also remote supervision through mobile phones and providing security training for CHWs and supervisors. Oh, don't know what happened to the slides here. Okay, down to gender. Yeah, thank you. So in terms of gender, the literacy requirements that I mentioned before, this really, when it was difficult to find highly literate or people with a lot of education in rural communities, this would affect the ability to hire female CHWs because they were less likely to have high education than the men. There was a stark lack of women in supervisory or administrative roles. There are also additional security risks for females, and CHWs, there were positives for female CHWs in terms of the job provided them with income, additional knowledge, social status, and freedom to travel. Next slide. So there's just some key lessons learned here. I think I'm gonna skip through this since I've used up my time. So I'm just including these in these slides so people can go through them afterwards. If we move on, also there are some research questions here that I'm not going to go through, but again, it's good to look through these if you have an interest. The key point here is in the research questions, the vast majority of the literature were really sort of case studies and qualitative assessments of programs. There was very, very little, almost nothing in terms of rigorous quantitative assessments of service delivery of CHWs in humanitarian settings, evaluation of effectiveness. So really encourage people to start thinking about undertaking this rigorous evaluations in these settings. And final point here, there's a collection on community health and emergencies in the Journal of Global Health. All of those case studies are already there, and this Lit Review publication should be up in December. So I encourage you to look at those papers there. And my email is also in this presentation, and I'm happy to receive questions for anybody. Thank you very much.
Thank you very much, Nate, for this very good presentation. Provides a very nice overview of what is known. And we are looking forward to the final report of this scoping review, and we will also send it around in our TWG. The next presenter is Dr. Wadja Wouri, and she is the Dean of the Faculty of Nursing and a senior lecturer at the College of Medicine and Allied Health Sciences at the University of Sierra Leone. And she is also involved in quite a lot of health systems research in Sierra Leone to contribute to effective policymaking and practice. Hadja is going to talk about the role of community health workers in disease outbreak settings. She is covering Ebola and also, I believe, partly COVID-19. So please, Hadja, go ahead with your presentation. Thank you.
Thank you very much, and good morning, good afternoon, good evening, everyone. Can I have the first slide? Okay, so I am based in Sierra Leone, and I thought it's best I start off by giving you some insights as to how the national CHW program has evolved in Sierra Leone. So in 2010, thereabout, in the wake of the Free Healthcare Initiative that was rolled out by the government to provide health services for pregnant women, lactating mothers and children under 5, UNICEF deployed quite a number of CHWs under the Free Healthcare to support the implementation of that initiative. The first CHW policy itself was launched in Sierra Leone in 2012. And but then what we had, this is the pre-Ebola phase, was that a lot of these CHWs were being supported by different donors, different partners. But then in the wake of in the middle of the Ebola outbreak, the role that they play in maintaining health services and supporting health services was shown then. So they were at the front line at the community level. They served as social mobilization contacts, social mobilization officers. They served as contact tracers and also as community-based surveillance at the community level. And if you take your mind back to Ebola, there was quite a level of mistrust where taking messages from outside the community into the community, you will not be welcome. But then CHWs were strategically placed. They were within their communities. In most cases, they were put forward by their communities to serve as CHWs. So they were seen as sons and daughters of the soil. So there was they trusted the messages that they were giving to the communities about the no-touch policy, the safe burial, so on and so forth. So they played quite an important role during the Ebola outbreak at the community level. And as a result of that, that was recognized at the national level, and a policy statement was made by the then president of Sierra Leone that the CHW should be formally absorbed onto the health sector, because before then they served as volunteers, as I mentioned earlier, being supported by other partners. And that started the process of having a national CHW policy. But the preliminary work that needed to be done was geo-mapping exercise of CHWs to find out where they are. And that was conducted in 2016. And in 2017, the CHW policy was rolled out. And that made way for 15,000 CHWs to be trained nationwide using a training of trainers approach. And next slide, please. And as part of the Rebuild study, where we looked at ways in which we can support the sustainability of that CHW program, and also how best the structures in place can ensure that CHWs are adequately supported. We conducted some key informant interviews at national level and also at district level. And some of the quotes that came out from that study, for example, one of the quotes there is saying, before then, as in before this new CHW policy was rolled out, it was very fragmented. Several partners were implementing different community health programs and working with different CHWs. And then the other quote is saying, so they came up with a national policy. All partners working with CHW program worked with the Directorate of Primary Healthcare through the community health worker hub within the ministry to ensure that there was coordination of efforts. So one quote is talking about the fragmentation before the new policy was rolled out, and the other quote is talking about how the structures were put in place, coordinated by the CHW hub within the Directorate of Primary Healthcare at the Ministry of Health, to ensure that all donor efforts are being coordinated through this unit. Next slide, please. Sorry, next slide. Okay, so as I mentioned, sorry, one slide back. Thank you. So in terms of community ownership and leadership, the role of CHWs during the Ebola outbreak was very, very important. And there's this quote that I came across that I think it summarizes exactly how important they were. And it says, communities are not only at the front line of the response, they are the front line. And the role that CHWs played in the Ebola outbreak was that they promoted a people-centered approach. As I mentioned earlier, they served as social mobilizers, contact tracers, and the data shows that just under 97,000 EVD alerts came from CHWs within a 6-month period. And they also served as burial team, and within the burial team at the community level. So it was very much important what they played, and we needed that at the community level, because Ebola, especially at the beginning, nobody really knew how to handle the situation. But then CHWs were strategically placed to do so, and they could work at the community level and promote the bottom-up approach. Next slide, please. And they also helped bridge the gap between the communities and the primary healthcare level. and this led to an increase in service uptake and service utilization. Because in the face of a disease outbreak, you want to manage the situation and deal with the disease outbreak, but at the same time, you want to ensure that essential services are maintained. So the CHWs helped bridge that gap and helped support the maintenance of these essential services. And as their role is centered around child and maternal health, they continue in the delivery of the reproductive, maternal and neonatal health program. They were acknowledged as core to the primary healthcare delivery system in the face of the Ebola outbreak. And this led to the establishment of a community ownership pillar as part of the post-Ebola recovery plan, where quite a number of different pillars were put in place. And there was one looking specifically in the post-Ebola phase, how to ensure that adequate measures are put in place to support community ownership and leadership in rebuilding the health system in the post-Ebola phase. Next slide, please. And then we also see that their role also had this positive ripple effect in the face of the COVID-19 outbreak. So a lot of the lessons learned from the EVD outbreak had this positive ripple effect in supporting the COVID-19 outbreak. For example, IPC measures. So there were Veronica buckets. We have what are known as Veronica buckets, makeshift hand washing stations around communities. And during the COVID outbreak, nobody had to tell them to do that. We knew what we had to do, and the community health workers at the community level were able to implement that. As you can see from the picture there, that's a makeshift hand washing station. So having the liquid soap in the plastic bottle and some water there. And that you see a lot of that at the community level. We also saw that at the community level as well, if you look at informal settlements, so slum communities, where if you think along the lines of what are the safety measures in place for COVID, overcrowding, so on and so forth. These are all characteristics of informal settlements, but then the use of traditional leaders working with their community health workers within their communities were able to pass on some of these messages and try to mitigate some of these challenges that were quite hard to address if you look at the bigger picture. So that showed that it was sustainable. It showed that there was knowledge translation and adaptability. But then, as with every disease outbreak, all health workers at the front line should be given adequate support in terms of psychosocial support. So again, CHWs, if they're at the forefront, the work that they're doing is quite valuable and it translates into positive health outcomes, then they should be supported in terms of psychosocial support, and also ensuring that they're adequately incentivized to continue the work that they're doing. And this will ultimately ensure that the work that they're doing promoting community resilience in the face of a disease outbreak is sustained. Next slide, please. Okay, and then if you look at that in terms of learning for equity, access and delivery for health services, maintaining health services. A couple of years ago, there was an immunization equity assessment that was done in Sierra Leone to try and address what are the bottlenecks to getting immunization equity. So the key challenges that came up was in terms of geographic accessibility and also the lack of health workers. And CHWs, again, are strategically placed to address that. Some communities in Sierra Leone, they're quite hard to reach. So it's quite difficult for other health workers to penetrate these communities. But then if you have CHWs already within these communities, then the problem of geographic accessibility will be addressed. And in the same vein, health workers are not adequate, but then if you have CHWs adequately trained and supported within these communities, they can address some of these challenges and support achieving immunization equity. So it shows that CHWs, they have a very important role to play with regards to trust in the health sector. They have this interface role. They can challenge societal norms. They can challenge harmful gendered norms. And these are things that came out from the Rebuild project, and the outputs from that are available on the Rebuild website. And it shows that ultimately, collectively, this has a role in supporting community resilience in the face of a disease outbreak, and also ensuring that other essential health services are maintained, and the disruption to the health service can be better managed. Next slide, please. So the final thing that I want to say was there was a knowledge, attitude and practice survey that was conducted a couple of years ago, and it asked a question about the role that CHWs play, for example, again, using the example of vaccination. And you can clearly see that the community health workers are valuable in that sense. So if when asked, have you ever visited a community health worker, 67% said yes. And when asked the question, community health workers, have they ever discussed vaccination during the visit? 99% said yes. And when asked the question, do you trust the vaccination message by the community health worker? 98% says yes. So it shows that what runs through all of this is that CHWs, the community trust them. So in the face of a disease outbreak, if we were to extrapolate that to a disease outbreak, then CHWs are strategically placed to support the response at that level in disseminating the right messages, serving as social mobilization officers, and ensuring that health services also are maintained, and that the gap that usually crisis disease outbreak can create between the health system and the communities is being addressed. Next slide, please. And I end on that note, and I say many thanks to the Rebuild project, which was funded by FCDO. And as I mentioned earlier, the outputs from this can be found on the Rebuild website. Thank you.
Thank you very much, Hadia, for this very nice presentation on Sierra Leone, the community health worker program coordination there, and the role of community health workers in disease outbreaks. Really very valuable presentation. Let us quickly move to the next one, which is presented by Amouda Baba, and he is the Executive Director of the Institut Pan-Africain de Santé Communautaire in DRC, and he's also a PhD student at the Liverpool School of Tropical Medicine. And his presentation is about community health workers in situations of extreme fragility in DRC.
Next slide, please. Yeah, hi everyone. I'm Amouda Baba from DRC, and I'm speaking on CHWs in the situation of extreme fragility. And I'll be examining their role in maternal and newborn health and other components. So our presentation will cover the DRC context and the type of CHWs, and also CHW's role in maternal and newborn health. And also we'll speak very briefly on CHWs and the gender-based violence, and then the role of CHWs in prevention and mitigation of gender-based violence. Next, please. So the DRC is located in Central Africa, so populated over 90 million people and an area of 2,345,000 square kilometers. And it has been classified among the countries with high fragility, which is exacerbated by decades of violence and conflict. So the country is also characterized by weak health system and also showing poor health indicators. And apart from that, the country experiences a severe shortage of skilled health attendants, contributing to the promotion of close to community providers, such as CHWs. So in the country, we have 3 different types of CHWs, but the 2 are much more common. We have the site CHWs, just involved in providing basic curative care in rural settings. And we also have promotional CHWs who are much more involved in promotional activities or raising awareness campaign in the community. So the third one, which is not all over the country, just in some provinces, and they are much more involved in specific programs in the countries where there is really need. Next, please. So what is the role of CHWs? I think from the two presentations, they've mentioned it. So they bridge the fragile health system with the community, because the community goes through via those CHWs to reach the health system. But they're also in a unique position to understand and quickly transfer some health concerns at the community level, and including maternal and newborn health related issues. So CHWs are more likely to be female, and that is something very particular in this area. And due to gender norms, they are already involved in health within families. Even before being CHWs, they were already playing the CHWs role by the fact that according to some gender norms, and women just are exposed to deal with that from their community. Next, please. And this just shows some activities of CHWs, and as we've seen it. So in relation to CHW's role in maternal and newborn health, so as I said before, all the female CHWs, they have experience of looking after pregnant women, babies, and children in the community, because they've been doing that even before being a CHWs. And women within the community are more confident interacting with female CHWs and in relation to some health issues that they face. And also we have female CHWs, they provide health information to women in the community, because when they need them, they are there and they understand the women's problem, and the women are very open to share their problems with them so that they could get some advice or some orientations. Next, please. So some very brief on CHWs and gender-based violence. And actually CHWs in DRC work within the same gender norms and power relation that influence the communities they serve. And sometimes they just have to comply with that. Otherwise, they might be facing challenges when they want to implement some of the activities in the field. And the programs often deliver a service which reinforces rather than challenges gender inequity. And this is the way the programs are really set in place. And in some cases, it's one of the factors which really contribute to gender inequity if they don't look at it very carefully. But in most cases, gender influences male and female CHW's ability to perform their role because of the influence of gender norms within the program. For instance, if assuming that you are having some activities in relation to women and maternal health issues, and you've got a male CHWs to go and talk about those issues. So it creates quite a kind of tension within the community, because the women don't feel safe to share some of the issues with those women. So as I said before, they're much more open to sharing with older female CHWs in the area. So that's why this happens. Next, please. CHWs in rural DRC are more likely to be female and also over the age of 30 years, because it assumes that they've already acquired enough experience in dealing with some health-related problems within the community, dealing with women and children, and also pregnancies in the area. In a recent case study, which I conducted just in 2 districts in northeastern DRC, out of 1,320 CHWs, so more than half of them were female. And men were seen to be less committed to role of CHW because they're just there for a while in case there is no opportunity. So once they get a paid job opportunity, they just leave this position, sometimes without even informing some health authorities, including those head nurses who are actually supposed to manage them. Next, please. So CHWs in their role in prevention and mitigation of gender-based violence. And we have CHWs, as I said again before, they are well placed to understand gender norms in their local context and act to counter them. So someone put it before, they are really the front line, because in case there is any problem in the community, so they are the one to identify those problems, and they know how to channel the problems at the normal level. And in some rural areas of DRC, you find traditional birth attendants and also some traditional healers, and also other CHWs. They use this trust they have within the community, this relationship they have within the community, in order to overcome some gender-related challenges, because they know, having understood the context, having understood the problems, having known those gender issues, so they use this trust they have and the relationship they have, so that they could overcome some gender-related issues, so that the health of the community can be improved. And that can be seen in the improvements of demand for maternal health and newborn services as it increases. Because in general, actually, the utilization service of the utilization service rate in the Congo curative, it's less than 40% of the population uses, and this is actually increasing because of the interventions of CHWs. And recently, we have troubles. So there are still conflicts in the area, in the northeastern DRC, about Ituri. And in one of the reasons, there are many displaced people. So when there are these displaced people, internal displaced people in the area, so you find CHWs who women first approach for support in case of different issues, such as sexual gender-based violence or health issues or other requests. Because mostly children and women, they live from the conflict area, they live in the camp, and some very few men also join them, but most men remain just to make sure that they protect some of their goods in the field and also the food they grew. So women and children find themselves in the camp with their female CHWs, and which understands their language, which understand their context. So in case anything happened, they just open up to that CHWs, and that CHWs know how to provide the support they really need. Next, please. So thank you very much for this short presentation. So you can find further details on this short presentation. Just there are some references which are there. So just go and visit to learn more about these CHWs in fragile contexts. Thank you very much. Next and last, please. Thank you very much.
Thank you so much. Thank you so much, Amuda, for this presentation. The role of community health workers in extreme fragile context and their trusted position within communities, also to respond to gender-based violence and to really, have this contextual information that they have is very important. Thank you so much. Our last presentation is from Alon Ghanizani, and he is the Deputy Director of Preventive Health Services, and he is also the Sector Chair of Disaster Preparedness at the Ministry of Health in Malawi. We have a recorded presentation from him about the role of health surveillance assistants, which is Malawi's largest paid community health worker cadre, during the cyclone Idai that hit part of Malawi in 2019. Let us listen to the presentation of Alon.
Hello, everybody. This is Alon Ghanizani as a way of introducing myself. From Malawi, Central Africa, making a presentation on the role of frontline staff in the Ministry of Health, known as health surveillance assistants. And this is specifically in the cyclone Idai that hit our country in 2019. Further to my introduction is the issue of, yes, I'm working in the Ministry of Health, in the Directorate of Preventive Health Services. Specifically, my section is that of environmental health services. And this is the outline of my presentation. I'll talk about the background of the health surveillance assistance, abbreviated as HSAs in Malawi, health impacts of the 2018-19 Cyclone Idai, and the role of the HSAs in the response to this disaster, the challenges we faced, and some recommendations. The brief background of the health surveillance assistance in Malawi is as follows. After working as volunteers in late 1960s, specifically 1969-70, in the vaccination campaign to eradicate smallpox, which was a global activity, these community members and volunteers were deployed again in 1973 to help with the control of cholera outbreak, which hit the country for the first time in that year. After a successful containment of the 1973 cholera outbreak, the Ministry of Health, that's the government of Malawi then, decided to recruit and retain these workers on a permanent basis as frontline health workers, operating from within the community. They were called cholera assistants. After working as volunteers in 1969, like I said, they were at this time championing water, sanitation, and hygiene promotion activities in the communities, considering the cholera issue. Their presence augured so well with the concept of primary health care and community empowerment, 1978, the time we started talking about this concept of PHC. Their scope of work was widening, but within the Directorate of Preventive Health Services, where these HSAs were working and to continue to be housed. And their name this time changed to Health Surveillance Assistance I'm talking about. Today, HSA's duties include areas in the clinical and nursing services. That's in addition to the preventive health work they are actually doing. Because of the numerous tasks these HSAs perform, some of their tasks now are being shifted to community health volunteers. And they are actually, these volunteers get supervised by the same HSAs. Around mid, now about the impacts of the Cyclone Idai. It was specifically 14 March 2019 that a tropical cyclone known as Idai made a landfall within Mozambique, causing what is considered the worst sudden onset of emergency to hit Sub-Saharan Africa in 2 decades. The impact was estimated to have caused over 1,000 deaths, over 240,000 people displaced at the height of the crisis, and about 3 million in need of assistance. This included 1.5 million children under 18 years of age across Mozambique, Malawi, and Zimbabwe. These are the 3 countries that were hit by this cyclone. In Malawi, 15 districts and 2 cities, largely in the southern part of the country, were affected. Many health facilities at the community level became inaccessible or indeed destroyed. Some of the specific roles of the HSAs included provision of health data of affected communities and villages to the next level of reporting, provided essential health services such as temporary village clinics and immunizations to communities in areas that became almost impassable and inaccessible by cars. Conducted preventive and promotive activities such as port chlorination of water because waters were actually scarce, especially for household chores. Distribution of mosquito nets, because those that were internally displaced had almost their belongings at home destroyed, washed away. And that included even the mosquito nets themselves, even other medicines that were for those that were on chronic treatments. Part of the healthcare team on the camp management, they formed part of that. Now, coming about to talk about challenges that these HSAs or frontline health workers faced during this time, some of their HSAs houses, which also worked as village clinics, got destroyed by the flooding waters. Village clinics, these are the clinics in the hard to reach areas that are actually manned by the HSAs. And they principally target the under 5 children. But this time, their scope of work had to include even others above the age of 5. Inadequacy of equipment and related resources failed some of these HSAs from conducting disinfection, rather infestations in the camps that were actually reported, such as cockroaches, bed bugs. It was a challenge. Lack of appropriate transport failed many of these HSAs also from effective delivery of health services at the community level. Multiple reporting tools by the national level response implementing partners overwhelmed the HSAs. They report to this one and they have different data elements to capture, and therefore recommendations include climate change, resilient health posts. This is where the HSAs stay. That should also include the construction of houses for the HSAs that are resilient to climate change issues. And that could ensure continuity of service delivery even when disasters hit. Appropriate equipment, transport, such as motorcycles, and related other resources must be made available for the HSAs for the same purpose of ensuring continuity of service delivery at that level. Review of national level data collection tools, reporting tools, and merge related ones to enhance coordination because of the reasons I said earlier on. And basically, I would say thank you for your attention.
This was the presentation of Alone from the Ministry of Health of Malawi about community health workers and their response to a natural disaster. Thank you so much. It is now time for Q&A and discussion. So I invite all the panelists to unmute and start their videos. We had some questions coming in. Let us have a look at them. I have some questions for Nate, 2 of them. The first is about community health workers as health activists or advocates versus service deliverers. Did you find out from the scoping review if there was some notion about them being more on the activist side also? And then there was a question of Rima Nakash about sustainability of community health worker programs, which is important in fragile and non-fragile settings, especially about financial incentives, that when these programs stop, the financial incentives also often stop. And it has also, of course, to do with donor coordination that Haya was talking about. Can you react to these first questions?
Yeah, thank you. So, and the question about using CHWs as health activists, the vast majority of papers are more about them extending formal health services. And I think that's what we tend to see today as their sort of extension of health services. The papers that did talk about them as health activists generally were from the 1980s and from Central America. So there were some papers from Nicaragua, El Salvador, Guatemala, that really emphasized their role as health activists and the importance of sort of being that voice for the community and motivating and encouraging and mobilizing communities to sort of to work on their own health and improve their own health within the community. But those were, only a small number of papers that really focused on that. And on the second question about sustainability, so in terms of sustainability of the services themselves, it was really about funding. So the cases of short-term funding we see even in development settings, I think, but then especially in humanitarian settings, we're looking at really short funding cycles. And so, for example, in the case study that we did in Yemen, they were doing ICCM, and then there was a program for a year, and then the funding cycle finished and they didn't get renewed. And so it just closed, even though the need was the same or even greater than it was when they started. The funding just disappeared and those services disappeared. So that's on sustainability, and then also integration of CHWs into the health system, encouraging sustainability as well. And the government, then donors and the government to really have motivation to continue funding these services and make sure these services continue if it's really a part of the government services as opposed to just some NGO program. And in terms of maintenance of services, so the CHWs may have been there, but then not providing services. This was usually because of weak health systems. Often in cases where health systems were weak to start out with, then they would perform less well when the emergency hit, and stronger health systems would perform better. We saw this in the case studies of Ebola. For example, in Sierra Leone, the CHW programs, I think, were a bit stronger than they were in Liberia before Ebola. And the Sierra Leone program seemed to continue a bit better than the Liberian program because of that. And then also support CHWs and clear policies were really key to maintaining the services when the emergencies hit.
Okay, thanks a lot. Just dropping in another question for Amuda. It's a question from Arpana Kulu on community health workers addressing gender-based violence. And as they are part of the same communities, really embedded in those communities, it might be that they themselves are also vulnerable for this type of violence. Can you reflect upon that?
Yeah, thank you very much. I understand that CHWs, as they are embedded within this community context, and in case of violence, they can
maybe the connection is not optimal. Let us move to another question from Mega Geerdar. That's about COVID-19, the current pandemic, and the role of community health workers in there and the challenges that they face. I guess they must be quite similar to some of the challenges that we have been talking about, but maybe Hadia, you can react upon that question.
Thank you. So I think, yes, it's been very similar, the challenges that they have faced in the face of Corona and in the face of the Ebola outbreak. But I think as with any disease outbreak, the more we learn about the disease itself, the more we can pass on that message on, and that message eventually trickles down to the community level, with the CHWs being the messengers, so to speak. So I think in the beginning of any disease outbreak where we're still trying to figure out what is going on, then there's usually fear. They're faced with fear, some level of mistrust as well. But then the more we know and the more we be open and transparent to them, then with time, as the outbreak evolves, then those challenges are addressed.
All right. And there was also a question about the potential COVID-19 vaccine. And there has already been talks about that in Sierra Leone and the role of community health workers in there.
Mm-hmm. So I think for that one, the data that I presented about the role community health workers play in achieving immunization equity, I think it's all very favorable. So I think, and they're trusted. The information that they give to the communities, it's trusted information about vaccines. So I think it's a platform that's already there that needs to be built upon. So I think they're strategically support that as well.
Yeah. Thank you so much. Back to Amuda, you're back.
I'm sorry, I had a connection problem.
No problem.
And I said you can have the CHW from the same area with the community where they serve. So the challenging bit is if in that community you have two different groups in conflict. So if the CHW is from one group in conflict, then during the trouble, their movement to the other community will be a challenge. And what they normally do is before doing anything, they just have to assess the security situation every morning, every daytime, every evening, just to make sure that they are safe before going to do anything else. So they knowing their context, knowing their people, and knowing this environment they really operate. So they are very mindful on assessing the security conditions before going any further, especially as far as their transport or their movement in the area is concerned.
Yeah, thank you so much. I see no more questions from the participants. Oh, there's one coming in. For health systems that are devolved, community health workers can sometimes get politicized because they report to their local elected officials instead of Ministry of Health. How can the national level ministry address this? Okay, that is not necessarily in fragile context, but also generally. Is any of the panelists would like to respond to this question?
Would you come to it again, please, Marcy?
Yes, sure.
There's a question.
There's a question about in devolved health systems that sometimes community health workers can get politicized and report and work more with local elected officials instead of with the National Ministry of Health. Maybe if any of you have experiences on this or reflections on how to address this issue.
Yes, in Sierra Leone, we have clear communication channels, and what I mean by that, the CHWs have clear reporting lines, and that feeds back to the national level. So the CHWs are supervised at the community level by their peer supervisors, and they in turn are supervised by the in-charges within the health facility. The health facilities report to the CHW focal person for that district. The district then reports to the regional coordinator, and then the regional coordinator reports back to the CHW hub that sits within the ministry. So for Sierra Leone, and that works really well. So it's having that clear communication reporting channel, and which from the national can be sent down to the community level as well.
Okay, so you have a clear system of communication between those different levels. Yes, Amuda, would like to contribute?
Yeah, thank you. I think we have something very similar with Sierra Leone, but it's not as structured as the one of Sierra Leone, which seems to be very clear. In the DRC context, actually, from the selection process of CHWs, so being selected by those community, and you have a number of CHWs, they make what they call the community animation group. And that community animation group, so if there is anything related to the communication on CHWs, it goes to community animation group. And each community animation group, they have the chair, and that chair has to report now to the health center, especially to the head nurse, who is the supervisor of those CHWs or community animation group. So the political influence is very, very low because they are well supervised by the local health systems at the local level, and the channel of the communication is well set. So no one can do anything else apart from what has been decided from district level. So I think from the channel, it is much clearer. But I think the experience from Sierra Leone is much better. It goes up to the higher level, whereas in the Eastern it's just limited in a way at the district level. But now to think how to take it from the district to the provincial and then to the national level, this is something which needs to be explored.
Okay, thank you so much, Amuda. We are approaching the end of this session. We had little time and we started a little bit too late. We are sorry for that. We hope that you enjoyed this webinar, and please stay tuned with the thematic working group on community health workers to really get some involvement and more information about this. Community health workers, we have seen it from the presentations, they are key health providers and trusted and preferred health providers during emergencies and in conflict settings. So they need to be involved in not only the response, but also preparedness and recovery afterwards. I think that is a takeaway message that we should, that we should take from this session. I would like to thank all of you, the participants of this session. We are very grateful that you were there, and please send an email to Faye Moody that you are seeing on this slide. If you would like to join our thematic working group, you're very welcome to share more learnings on community health worker programs worldwide. Thank you very much and have a good day.
Thank you.
Thank you.
Thank you.